Good morning, everybody of you. And first of all, let me express my gratitude toward the organizers. Especially, I am thankful to Srinivas and Dr. Pradeep for giving this opportunity. Srinivas has already eased out some of my jobs after explaining and going deep into the basic mechanisms of maintaining the body balance also. But my presentation is, I won't say it is very much advanced, but probably it is focused on understanding some of the confusing situations clinically. And with the list of the investigations, how can we manage the cases of BPPV? I started practicing in field of vertigo somewhere in 95 or so. And I was quite blind that time. And probably I was knowing only two things as far as vertigo is there at that time. That is, either it is caused by the hypertension or it is caused by the hypoglycemia or so. But then gradually with the acquaintance of the knowledge, then I started recognizing different colors in the vertigo. Well, when we want to know something new, when we want to do something new, then we had a stimulus. We have got an impetus, but then what we need is a limpidity, that is a clearness, transparency. And that was not there with me those times. Now I remember that one of my friend who met with a fatal accident died of the chest crush injuries at Lonavala, somewhere near Pune. And he used to come to me for the treatment of vertigo. He used to go to my teachers also, and suffering for almost 5 years before he died. And unfortunately, he was not diagnosed then. So with the request to his parents, then we got his autopsy done after the death. And this is what it shows. You see that the lateral canal, this superior canal. Okay, and you see these particles. This is what the PR, this includes particles in the canal. And when we put it on the higher magnification, we could see, sorry, we could see this is the cupola, section of the cupola, and see the particles over there. And this has clarified that the horizontal canal is not just a problem as far as the BP is concerned, it's not just because of the canal lithiasis. It can be because of the cupulithiasis also. So then the clouds were off, and then I started managing the cases in the better way. Now initially we had a clinical approach and AIMS to differentiate between peripheral and central type of vertigo, to rule out RC lesions, to look for association if anything is associated with the cochlear hydrops, whether it is because of Meniere's or whether it is because of trauma. And also, is there any correlation with all these findings of BPPV with cervicogenic vertigo? Cervicogenic vertigo has been always a debatable issue, and then we need to consider certain points to definitely diagnose it as a positional vertigo. Then comes the point that it differentiates between canal sites, whether it is occurring with the posterior canal, with the lateral canal, or occasionally with the superior canal. And to differentiate between canal lithiasis and cupulolithiasis. This is a cohort study and taking 1/10 of the patients in a form of cohort. The female to male ratio not much significant I find, but little predilection is there for females. Healthy patients without spinal abnormalities, gross obesity, coronary heart disease, systemic diseases, pregnancy, etc. have been ruled out. Symptom duration was between 15 days to 2 years. In fact, recently I got a patient who had a history of 5 years and was on medicinal drugs and rehabilitation program but not relieved. Vertigo was present in all 32 cases. Tinnitus and deafness was there in 3 cases, and neurovegetative symptoms were present in 5 cases. Vertigo coming from supine to lateral posture was seen in 21 cases, and from sitting to lying down and vice versa in 5 cases. Either change in the posture was there in some cases. Vertigo is better with the closed eyes. Now this is a very practical tip. Most of the peripheral vertigo, they improved, or the patient says that he is eased out by closing the eyes, in contrast to the central type of vertigo. So these are the investigations, but main thing I would like to say that when you are doing Hallpike test, then you need to differentiate between whether the nystagmus is of geotropic or apogeotropic. Now this is the comparative test between, this is the test we have developed. Instead of Hallpike, we do the Hallpike, and also we do the modified test of our own. So instead of turning the head to 45 degrees and ask the patient to lie down, putting the head to 30 degrees, we directly from sitting position, we bring the patient back and lower the head to 30 degrees and then turn the head at 45 degrees either way. Now how that helps, I shall explain you later. Well, these are the figures, and you will see the combined, if you are going to use both the tests, positional tests, then probably your rate of diagnosis goes higher. Now this is the initial observations when we do this test. The geotropic with the fatigability was found in 13 cases. Apogeotropic with the fatigability was seen in 3 cases. However, apogeotropic is known with the non-fatigability picture. This is a very cardinal observation. When after doing 2-3 times this positional test, then probably picture changes. And the geotropic is seen with the fatigability in 15 cases. That means some of the cases of apogeotropic nystagmus were converted into the geotropic one. And apogeotropic with the fatigability was seen in 1 case, which was initially with the 3 cases, and poor fatigability was seen in 16 cases. I shall, there is a problem with the computer, so I shall show you the animated film later on. So based on the observations, we classify the horizontal canal BPPV. There is not much to talk about the posterior canal because all standardized Apple's procedures and all those things, so I won't go into detail, but most challenging problem, what I found at my clinic, more number of cases of horizontal canal pathology. So this is the HSC type, apogeotropic type 1 we label it. The problem is free floating particle in the entry part of the canal. This is convertible or liable for steadiness, either of it is possible. Then we come to the second type, that is the geotropic one. This is a free floating particle in posterior part of the canal. This is a steady, it is not changing. Nystagmus is always in the same direction in spite of number of positional tests you do. And this can be easily maneuvered. And the apogeotropic type 2, that is the debris attached to the cupola, this is the non-convertible one. You can't convert it into the geotropic one. This is a fixed one. And there are the various maneuvers suggested for that. I'll be talking about maneuver later on, but this is the post physical therapy instruction. We usually forget. I used to forget. So these are the instructions. This should be printed out and to be given to the patient, because we do not have many times the time to explain. Patient do not have the same intelligence to understand in the same sitting. So it's better to give the printed this instructions. So restricting the neck movement in all 3 dimensions, this is very important. Use the stable support while climbing or descending, especially staircases. In case of canal lithiasis, cases of primary or converted into the geotropic nystagmus. Avoid lateral supine position on the affected side. Avoid lateral supine position in the affected side. Well, in case of cupulolithiasis, the thing is reverse. That is, avoid lateral supine position on the normal side and ask him to lie down on the side of affected side. And report after 2 days and again on 10th day. They can inform us on telephone or by mail or by any other communication method. If there is a recurrence or patient is not relieved after 48 hours, we call the patient again. Again, we try to establish a diagnosis, and again we do the maneuver. But this is required in few number of cases, maybe about 25% of the cases you require that. This is the mean follow-up done, and this is the comparative results of the canal. This is the posterior canal, Applause maneuver, we see number of sittings required are 1.2. In horizontal canal, we see the number of sittings required for 1.8. This is B is for barbecue. And with our own modification for the same horizontal canal, the number of sittings required are for 1.3. Occasionally, we have to give the head shakes. Now, head shakes, how it is given? Hold the patient's head, sit on the patient's head side, hold the patient head in your arm, in both palms, low down, say about 15 degrees this time, and give 20 shakes on each side. Give 20 shakes on each side. Now, this is supposed to work by moving the particles rapidly towards utricle. But this is not tolerated by many of the patients. Sometimes there are the associated problem. They have got a shoulder girdle syndrome, or sometimes they have got a phobia. So they won't be ready. But this is the last thing and very unusually done, head shakes. Now, why do you need to modify Simon's stage 3? This is the reason. Now, this is a horizontal canal with a 30-degree sloping. This is the natural position. Now, when you bend the neck backward by about 45 to 60 degree, this ampulla comes 30 degree above the horizontal plane. And this facilitates the gravity force to act. And the effective vector will be like this. So, if you do not ask the patient to extend the neck back and do the Simon's modification, I think everybody knows about Simon's modification. I did not go into detail. Shall I, Srinivas? Okay. So, this gravity force helps. So, instead of that, if you do not do this modification, the particle will stick to the wall, membranous wall of the semicircular canal, and may not get cleared up. But when you are using effective force, the gravity force, the particle will straightway go beyond the turn of the horizontal canal towards the posterior arm. And then there are more chances of clearance of the particle. So this is the incidence 15 to 20% in my clinic. And then especially we are managing to differentiate between canal lithiasis and cupulolithiasis. Now these are the practical points. The cupulolithiasis is characterized by anti-arm site cupular lesion. Vertigo lasts for longer spell. There are the neurovegetative symptoms like nausea, vomiting. Hallpike and wow, both tests are complementary to each other. Latency is nil. This can be repeated. The nystagmus has the character of getting repetition. And wow Simon's or head shake maneuvers would help to get rid of this problem. As against the canal lithiasis, the site is usually posterior arm or could be shifted from the anterior arm of the horizontal canal. Vertigo is a brief spell. Hallpike test is very characteristic. Latent geotropic nystagmus is also seen, and it is non-repetitive and barbecue maneuver with force prolonged positioning. Now, force prolonged positioning after performing barbecue maneuver or rollover technique, you ask the patient to lie on the affected side for at least 10 hours. So usually this is one of the source of creating a revenue by visiting the patient's home, because patient is really comfortable. Especially make the visit in the night time. Ask the gentleman or a lady to have light meals, pass the urine, and then do this procedure and ask her to lie down for 10 hours. If she is happy, she will automatically call you in the morning to say the good morning. Now there are the sometimes situation, which side is culprit, you do not know. Patient is not very clear on which side she is getting, on turning on which side she is getting a vertigo or so. So to evaluate the difference in subjective symptoms and nystagmus amplitude, Patients with a geotropic HSC-PPV rolling the head to the affected side provokes the ampulopetal deviation of the cupula. Positioning maneuver toward healthy side will result into the ampulofugal deviation of the cupula based on evolved second law, with less intense geotropic nystagmus. Similar considerations can be made for triggered apogeotropic and inhibitory type of apogeotropic nystagmus. So yet in doubt, presence of short-lasting nystagmus beating toward the healthy side during sitting to supine position in repetition shall provide the crucial clue. That means particle traveling to the posterior arm inducing ampulofugal endolymph flow, causing inhibitory nystagmus. So pathological site detection is based on the correlation in nystagmus sign and intensity, that is the speed with the clinical history. Apogeotropic cases are tried first to convert it into the geotropic one. Barbecue maneuver is advocated for geotropic and Wow-Simmons modification for apogeotropic nystagmus. This is a comparative outcome with the control as well as with the force prolonged positioning. Now this 3 weeks, 6 weeks, 9 weeks and 30 weeks. We could follow up to 30 weeks. And this is a drug and habituation will result this, ultimately will give this much result. This is again a good series from Nuti, and this was followed for 6 weeks and has yielded in the horizontal canal 40% cases were not relieved and 60% results were there. Similarly, by Appiani, you see the results are going up to the nearly to 90%. And in our series, the same thing, but we have got a bit longer follow-up than other comparative trials. So nystagmus feature site and site of horizontal canal lesion decide the option of physical therapy. Barbecue plus force prolonged positioning for geotropic and Wow-Simmons and for apogeotropic nystagmus. Almost guaranteed effective removal of debris from canal with combined effects of these maneuvers. Almost guaranteed. So we don't give in writing that 100% guarantee. Okay? And larger sample study, still, if anybody has got, I'll be most eager to hear those. Now we come to the next important issue, that is failures in PRM. The hypothetic possibilities are incomplete dislodging of the particles from cupula, as everybody understands. There could be the re-entry of the particle. At a time I have seen initially the patient with canal lithiasis corrected with barbecue, coming after 3 months or so, 3 months totally symptom-free, after 3 months coming, getting the vertigo, and this time I see the particle entering into the anterior arm. So this is quite possible. Suboptimal or incorrect maneuver, especially at the beginners, at the end of beginners is possible. And there has to be anatomical consideration. When I had a discussion with Anirban, he said there are some acute bends in the horizontal canal, which probably helps in non-clearance of the particle. However, this has to be documented, but this was his hypothesis. Well, after considering these points in failure, are we still missing someone? Are we missing some more entity? Let us see. In between, I had an opportunity to go through certain literature, and there was the literature from Talat H.S. Abu Hadid, and he was considering vitamin D deficiency, is it causing the vertigo or so? So co-occurrence of these two morbidities don't directly support pathogenesis of the BPPV, that was the conclusion. Again, BMD, bone matrix density, is insignificant factor to recurring or non-responding BPPV, as against vitamin D3 supplement bringing down recurrence from 43% to 18%. Of course, this was not a study pertaining to the canal pathology, this was the general pathology. So, what we tried to first see clinically, what are the clues for vitamin D deficiency coming? We have diagnosed the patient of positional BPPV, and still I am looking for those failures. First time probably we concentrate on the history, okay, and the related investigations. But when the patients come for the second or third visit, then I started looking for these clues clinically. Dark skin, blue filling, 50 plus age, obesity or higher muscle mass, bony aches, and head sweating or gut troubles any. And then we started investigation, sending the patient for vitamin D, let the pathologist and biochemist people earn something out of this, which usually they do not earn out of the BPPV. So these were the findings, and this is a failed group and controlled group. We had a trial, a failed and controlled group. This is BMD more than -1 was seen in 5, and in control it was in 3. So ultimately, this is less than 10 nitrogram vitamin D is a definite deficiency. Less than 20 is a medium deficiency, and more than 30 Ng is a normal, for your information. So 4 supplements, we again did the estimations, and clinically they were improved. Out of 10, out of 29 cases, 17 were improved. And this thing, the reduction in percentage expressed by the patient was seen up to 80% in A group, and in B group about 35%. So this is the additional supplementary therapy we are giving to the patients. The small series is conclusive for vitamin D3 deficiency, doesn't have predilection to affect specific canal pathology. There are no studies. Vitamin D से posterior canally affect होता है, horizontal canal, nobody knows. Supplements have favorable and better outcome in test group than the control group, irrespective of the canal types. So recommended doses of vitamin D3, there is a severe deficiency. You give injection intramuscularly 60,000 units twice a week, 30,000 units in sachet once a week, after that for 3 months. For moderate deficiency, 60,000 once a week and then 30,000 once a week for 3 months. And for mild deficiency, just give the oral forms, oral therapy in the sachet form for 1.5 months. So this is, I am just tempted to produce the protocol, what we are following at our clinic. If it is stable apogeotic, consider cupulothiasis, anti-arm pathology, go for Wow-Simmons maneuver, or if it fails, then go for head shakes occasionally. If it is unstable apo or geotropic, such as the canal lithiasis, pathology could be in the anterior as well as the posterior arm. Try to convert it into geotropic one. If it fails, then go for Wow-Simmons maneuver. If it doesn't respond, then go for the evidence-based vitamin D supplement. For stable geotropic canal lithiasis, we perform barbecue maneuver. If it fails, then go for vestibular adaptation and the vitamin D supplements. So one can wait for the dawn. One can wait for the dawn. There will be some light, there will be some transparency, there will be some clearance, there will be some clearing of the doubts. That is dawn. But then we have to keep the lamp of knowledge burning for that. With that. Where is that compartment? To show the film. Plane. This supine position. Now, supposingly this is the spontaneous stigma settling soon, and then you are, see the changing the nystagmus. Now you are turning the head on the right. Okay? And now you see the particle traveling toward the ampulla. So this would suggest the apogeotic nystagmus. Just, I am not able to play this film in the slow speed, otherwise you could have appreciated in better way. And now you see fast beating nystagmus. So this is the apogeotropic nystagmus of the right canal. And now if you are turning the head on the left side, it will be showing the nystagmus beating toward the left side. So this is the canal lithiasis. You see, here the particle is flowing toward the posterior arm. Now this is a barbecue maneuver. I think everybody knows. I will just go forward. But just see how the particle moves with the barbecue. This is the barbecue only. Now this is the modification of the taste. You see the neck is extended 60 degrees, and then we ask the patient to lie down immediately with the jug, so that the more chances of getting the particle dislodged from the cupula, and then turning head towards the earth by 45 degrees. So thank you very much for your kind attention.
Sir,
and if any questions are there, you are welcome.
Sir,
yes, Pradeep.
Few clarifications. Why will you ask the patient not to move his neck in all the 3 directions after a positioning maneuver? This is number 1.
Well, these are moving the head is always a complementary. What happens now? Supposingly, if you have corrected the position, say for canal lithiasis of the right side, okay. So when the patient is going to move the upside, sometimes what happens is the natural phenomena, the patient may again turn the neck on this side. So if you are giving, it's like a fracture, it's like a fracture. What do? You do the plaster, okay, so that the patient doesn't move. Because unknowingly or knowingly, even the brain commands at a time, you don't move this head, move the head on this direction and turn to this. And sometimes there are natural commands coming from the patient itself. So they do not follow the strict instructions, okay. And reflexly, supposingly, I ask the patient not to turn the head on the right side, okay, he will not turn. But somebody calls from this side, he will turn the head on this side. And then again he will remember, oh, I am getting something, because there is a reverse phenomenon occurring, okay. So again he will turn the patient to the right side. So it's better to, on the safer side, to control all 3-dimensional movements.
This was for horizontal canal. This was for horizontal canal.
Which one?
Okay. Sir, we will discuss later.
Okay, thank you.
Short of time. Thank you.
Thank you all of you for the patient listening. Thank you.
Thank you.